Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the School of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome to the program Scott Baker.
Thank you.
You are a pharmacist at Peninsula Regional Medical Center, and you've come in to talk about the important topic of blood thinners, medications that are used to thin the blood. And we know there's two major groups. There's your anticoagulants that work on venous issues, problems with the veins, clotting in the veins, and then another group, the antiplatelets, which are more focused on arterial blood.
Right.
So we'll start first with the anticoagulants.
Right, so anticoagulants, probably the most famous one that's been around the longest would be Warfarin. It's kind of old faithful, but in the last decade or so there's been some new ones, or novel ones as they like to call them. You have your Eliquis or Apixaban, you have your Xarelto or Rivaroxaban as it's called as well.
Well, let's start with Coumadin or Warfarin. That I know that has been around quite a while, and many people are on it and swear by it. But there's some issues with Coumadin. So I guess first tell us, how does it work, and what's it used for?
Right, so Coumadin or Warfarin is, we call it a vitamin K antagonist. So it kind of works against some normal proteins in your blood that help the blood clot normally, and when it kind of works against those, it keeps your blood more thin, makes it less likely to clot should there be something going on to cause it to want to clot more. It's a oral tablet. People take it by mouth, and everyone's a little different. There's different dosing strengths. You can take anywhere from 1 milligram to 10 or sometimes even more. It just varies from person to person. And you can take different strengths or amounts every day. Everyone's a little different. But with that, kind of how we follow where they're at with their warfarin and how thin someone's blood is as a result, we follow what's called the INR, which gives us a general idea of where the blood is. Generally, we shoot for the 2 to 3 range. There's a couple indications where you'd want 2.5 to 3.5, but that's generally how we do it. We'll start someone on it, we'll follow their INRs, and the pluses are that it is older and relatively cheaper. The minuses for it are is you do have to get that blood work done to follow the INRs, which starts off a little more frequently when we're first starting someone on warfarin. It might be every week or two, and then the more stable it is, the more we can space that out. But one way or another, patients have to come back and kind of get that level every so often.
So when someone's stable on stable dosing, then how frequent are the INR blood draws?
Well, it kind of depends on patient and physician comfortability. The most recent guidelines say you can go up to every 12 weeks, which is almost 3 months. In practice, I haven't really seen someone stretch it out that far, but if someone's stable, they could technically go out every 12 weeks. Generally, when we first start, it might be every week, and then they'll get people out to maybe once a month, every 4 weeks. And from there, it's kind of how comfortable is the patient with doing it, how comfortable is the physician with doing it.
So what are some of the main reasons a doctor or provider would prescribe Coumadin?
Probably the most popular ones are if you have what we call a DVT or PE, so you get a blood clot in your veins, either in your legs or arms or somewhere, and the concern is that that clot could travel through your veins into your heart and then into your lungs, where you'd have a PE that we call. So once you have one of those, it needs to be treated to kind of help the clot dissolve over time. So that's one of the main reasons we do warfarin. Another one is people with atrial fibrillation, or AFib as a lot of people call it. When you have that condition, your heart, the way it beats and the way blood moves through it, it makes your blood a little more likely to clot. So they kind of put people on warfarin or one of these other anticoagulants as a preventative measure to kind of help reduce the risk of developing those clots, which could ultimately lead to a stroke if they're not prevented.
And then also if people have mechanical heart valve surgery, they'll need to be on some sort of medicine to prevent clotting from that.
If someone has a mechanical heart valve, particularly a mechanical mitral valve, or kind of the main valve in your heart, that's the kind of one indication where people have to be on warfarin, or the other ones we mentioned, Eliquis or apixaban, that Xarelto or rivaroxaban, are not indicated for those particular patients.
So they would definitely be on Coumadin for that.
They would definitely be on Coumadin.
And I know people have heard about DVT per se, the clots in the legs that are especially common if you have surgery, you're at higher risk, orthopedic surgery and so forth. So that's where you hear a lot of people taking Coumadin.
Certainly. Anytime you're kind of immobilized or you have some type of surgery that kind of stops you from moving around the way you normally do, your inherent chance of having a clot goes up quite a bit. So you'll see some clot development in that phase.
And they say even sitting in a car for a long period of time, or a plane ride, or it's important to keep moving.
The older you get, the more you have to be aware of how long you're sitting still in car rides, plane rides. All that can increase your risk of having a clot as well. Hospitalizations in general increase the risk of having a clot. Smoking, obesity, things like that increase clot risk as well.
Now, before we get to the newer or novel anticoagulants, I mean, Coumadin, the downside is the blood work that needs to be done.
Right.
And also the fact that it interacts with many other drugs and also foods. You have to be careful with your intake of green leafy vegetables that are high in vitamin K because that counteracts the effects.
Right. And what we tell patients is warfarin interacts with a lot, but where we do follow the INRs, as long as you maintain a consistent lifestyle, you can kind of adjust your dose to meet that 2 to 3 range. So a big kind of counseling point that we like to stress as pharmacists is you don't want to tell your patients don't eat salad or don't eat your leafy green vegetables, but you should eat a consistent amount. So when you start warfarin and you're adjusting your dose with your doctor to hit that range that we're shooting for, whatever amount of vegetables on average and leafy green stuff that you're eating during that time, you want to try your best to stay consistent with that intake. Because if you say you don't eat any leafy green vegetables and then all of a sudden after you're on a nice adjusted dose you start eating a bunch of them, then it becomes an issue with the warfarin.
Right, right. Now, I know you wanted to also talk a little bit more about these newer anticoagulants, and they're called novel anticoagulants, or how do they work exactly? You're talking about Xarelto and Eliquis.
Right, so they are also anticoagulants, but they work a little bit different than warfarin. We call them direct 10A inhibitors. So your blood has this series of proteins, we call it a clotting cascade, that eventually helps blood clot when there's some type of provoking issue causing a clot. It helps it clot, and it's a natural response. But the 10A inhibitors, they kind of mess up a part of that chain that kind of prevents the blood from clotting as well as it normally does, which in these indications we talked about is beneficial because you don't want the clots to develop further or grow more if they have the AFib or DVT or PE.
So what exactly, do Xarelto and Eliquis have different indications, or are they too used for DVT? Of course, you're saying for the mitral valve, just Coumadin's approved for that.
Right, mitral valve, mechanical, just Coumadin. Generally speaking, there's very similar indications. Apixaban or Eliquis apixaban, they have an indication as well for specifically like post-hip surgery. You mentioned you have that increased risk. So kind of post-surgical, we call it prophylaxis, or basically prevention of clots post-surgically. They have an official FDA indication for that as well. But generally speaking, they're indicated for the same kind of DVT, PE, or general clot treatment and the prevention in atrial fibrillation or AFib patients.
And I guess we should mention, years ago, before we had these drugs or knew so much about them, DVT was quite common in the hospital post-surgery, and they can be deadly if they break off and get to the lung and cause a pulmonary embolus. People can die, but those rates have really dropped because we've learned so much about these medications to prevent that.
Right. I think we've come a long way, even in the last decade or so, of understanding who should be on preventative type stuff, who shouldn't be, and kind of preventing as much as we can while still trying to stay as safe as possible.
Right, and the other thing we wanted to talk about, especially with Coumadin more so, but it'll probably come up with other medications, is the genetics piece of it. that some people don't process meds the same way as other people, and this was discovered with Coumadin a bit back. So.
Right, so Coumadin does have some genetic variation, and everyone has these enzymes in your liver that help you metabolize most of your drugs if they have any type of the way your body breaks down medications. A lot of it's through the liver, and that varies from person to person based on your genetics. We call them CYP or CYP enzymes, but there's a few different ones that help your body process Coumadin, and that can vary from person to person. And that's kind of getting back to what I mentioned earlier about some people only need 1 milligram a day and some people need 10 milligrams a day. I've even seen in rare cases people needing 18, 15 milligrams a day, up in that range. But it all varies. At this point, they're not recommending genetic testing off the bat for any warfarin patient, but it is possible to get genetic tests to see kind of how your body will handle the warfarin.
I imagine if there's some disparity in how it's working or whatnot, then that could be the explanation.
Right.
Okay, let's move on to antiplatelets.
Okay.
And the most common one that I think most people have heard of is aspirin.
Right, so aspirin's been around a long, long time. Even before we knew it as aspirin, there's records of thousands of years ago, people chewing on the bark that had aspirin and whatnot in it. But it's probably the most well understood and most widely used of the antiplatelets, and it probably has the broadest range of indications. But generally what it does is your platelets, whereas the anticoagulants more affect proteins in the blood involved with that clotting cascade, the antiplatelets obviously work directly on your platelets in the blood, which are a little different. So if you have something like a plaque in your arteries or something that ruptures and leads to a heart attack, when that happens, your platelets kind of get activated and help. They think that they need to help wall that off and seal it, whereas in actuality that's what's causing your heart attack. So by inhibiting the platelets like with aspirin, then you kind of decrease the amount of platelets that kind of contribute to that process or are available to contribute to that process, so it thins your blood out a little more.
So aspirin's been used for quite a while now for stroke and heart attack prevention. So is it still generally recommended for that now?
Yeah, there's a lot of different recommendations for aspirin, and a lot of it depends on whether you've had a stroke or a heart attack. And there's a lot of debate on what we call primary prevention. So what that means is, should you take aspirin if you haven't had a stroke or haven't had any heart attack or heart disease? And generally speaking, they're saying no, but a lot of risk factors and other things weigh into that. So it's a discussion you should probably have with your physician, and they can make an educated judgment on a patient's risk factors for developing that thing, their age, their bleeding risk. It's kind of a balance of pros and cons, right? And they can make that decision. That's for the primary prevention, or kind of before it happens. But for what we call secondary prevention, or after the fact, so after having a stroke or after having a heart attack or after having stents placed in your heart, then it's 100%. There's a lot of strong data you should be on the aspirin, unless for some reason like you're allergic to it or something.
Right. Well, getting back to the primary prevention, are they generally giving the baby aspirin or the regular strength pill?
Generally it's the baby aspirin. There's some different indications where you get the 325 or the bigger dose, but that's more so not for the primary. Generally, it's the baby aspirin.
Well, one thing about aspirin, it's cheap, right?
Certainly. I mean, that's a huge benefit, and that probably has a lot to do with how long it's been around. But
exactly.
You can get it anywhere, and you can get a lot of it for a little bit of money.
Right. So that it depends on whether it's primary or secondary. I think I heard about a recent trial that came out about primary prevention, saying that you really have to weigh the pros versus the cons.
Right.
And one thing you didn't mention is the high risk for bleeding, GI bleeding in particular, especially in older adults. So they're saying that once you hit 70, it might be something you need to discuss.
Certainly. And that's, the bleeding risk is always a big factor with all these medications. Really, there's definite benefits to thinning your blood for some of the stuff we talked about, but on the opposite side of that coin, I guess, is your bleeding risk. So there's a lot of things that can increase patients' bleeding risk. You mentioned stomach ulcers being a big one, or maybe they have a falling risk, your elderly patients who are maybe more unsteady on their feet, and all that goes into that kind of pro and con weighing conversation that you have with your physician or doctor.
So now let's move on to the other medications in this antiplatelet category. And I know a lot of people have heard of Plavix or Clopidogrel. So talk a little bit about Plavix. That's been around a bit now.
Yeah, Plavix has been around for quite some time now, Clopidogrel, and it is an antiplatelet as well. It works differently than aspirin. I won't get too technical. They both work on the platelet, but they kind of approach the platelet from different receptors or sides of the platelet, but they ultimately lead to a similar platelet inhibition or kind of dulling down the clotting or activation of platelets for those disease states. But sometimes you'll see Plavix or Clopidogrel used in place of aspirin. It all depends. Sometimes people have aspirin allergies or stuff like that. It can be used in place of it. A lot of times in the guidelines you'll see if aspirin allergy, then use Plavix. And sometimes you'll see them used both together. A lot of times, like after a stent's placed. That's not something that should happen indefinitely forever, but there's guidelines out there for how long that should be, 6 months versus a year. And then after that amount of time's done, you can have a conversation with your doctor, and it's again a pro and con benefit of what's the bleeding risk, what's they call it restenosis, but if you have a stent, what's the risk of it closing off again? And then you kind of make that judgment call after your 6 months or 12 months, whatever it may be, for your dual antiplatelet therapy, they call it. So they're both antiplatelets, but it's not unheard of to see them both used together in patients.
So I guess that increases your risk, though, for bleeding.
It
so
does.
The benefits would have to outweigh that.
Right. It's a double-edged sword kind of. So having both of them on board, your bleeding risk does go up. But for things like a stent, if you have a heart attack or your doctor deems that you're close to having one and need a stent placed, the closer you are to that stent, the higher risk you have of the stent kind of reclosing, which could lead to another heart attack or something like that. So in that immediate phase afterwards, it's important to have that kind of dual action. But the further away you get from that event, the more likely that is to happen. So basically, the further away you get, the bleeding risk is still there, but your benefits kind of go away. So that's when you're weighing both sides again and kind of trying to decide what's the
balancing act, isn't it?
Certainly.
And I know you wanted to mention Brilinta. That's a newer one.
Right.
It costs a little more than Plavix now because it's new.
Generally, a lot of it depends, again, on people's insurances. So it's not a blanket statement. There's a lot of variation in the insurance market out there. But Brilinta's a little newer, brand name only product. Generic is ticagrelor. But it's the same class of antiplatelet that Plavix is, or Clopidogrel. So they work in similar ways. The Plavix is just once a day, whereas the Brilinta is twice a day. But Brilinta, more and more I'm seeing Brilinta being used more readily than the Plavix. And it's again, patient and provider preference. One thing I didn't mention with Plavix, but it also has a bit of a genetic component to it as well. The same enzymes that I was mentioning earlier in your liver, a certain percentage of patients may not have those enzymes to activate the Plavix into its active form. So you always run that risk with Plavix. So sometimes physicians, it's not as big of a risk with Brilinta, so they'll more readily roll out
use that one
the
instead.
Brilinta or the ticagrelor.
Because the downside is twice a day dosing too.
Right, the downside's twice a day
Having people
dosing.
remember to take a medicine twice a day instead of once. But
the other thing with Brilinta, sometimes decent, it's not more than half, but a decent percentage of patients can say when they first start Brilinta, they might have when they get up and move around, it might be a little difficult to breathe. But it's important to note with Brilinta that that's only when you first started. It usually goes away after the first week or so. But sometimes people will start Brilinta and then choose Plavix because of that. But it does go away if they can get through that.
Well, all of these you talk with your doctor
right
on
certainly.
How it's working, how you're feeling, the cost. All these things can be considered and decide what's the best medicine. I know you said there was a medicine, it's been around a bit, called Effient, but that one's not used as much.
Effient is in the same class as Brilinta and Plavix, or ticagrelor and Clopidogrel, but it's kind of fallen out of favor a bit for over the last decade or so. So it's not nearly as common. There is a small percentage of patients where you do see it used. It's a little more potent of a platelet inhibitor than the others, and that's kind of why it's fallen out of favor because of that. Maybe some concern for more bleeding risk with that one compared to some of the others.
All right, so let's wrap up some of the key points in terms of just general points. Like, for all of these, I've heard you mention or say several times, there's guidelines.
Right.
There's research, evidence-based guidelines that help with deciding which drug's appropriate when.
Right, so there's a lot of really brilliant minds out there, guideline groups for different indications, whether it be your heart attacks or your strokes. They all have their different groups, or DVT, PE we talked about, that every few years or so, depending, kind of update their guidelines for the management and how to best use these drugs to do this. And it's a conversation you can have with your physician. Everyone's pretty in tune with staying up to date on these big guidelines that come out. It's an area that pharmacists obviously enjoy a lot because it directly helps us decide best medication, time, dose, stuff like that, kind of overall therapy. And they change all the time, so it's important to kind of stay in tune with your own treatment plan and learn as much as you can about the medications, so you can be in tune with kind of where these suggestions are coming from as well. And it's all based on data that's out there on big groups of patients that they've looked at, and kind of determine what's the best path moving forward based on what we know now.
And we know how important it is for people to know what medications they're taking and talk to both their physician, provider, and of course the pharmacist can be a great resource for these.
Right, definitely. It's always, as a pharmacist, we absolutely love when a patient comes in and they know their medications off the bat, all of them in depth. Or maybe if it's an elderly patient or a family member or something that's not able to quickly recall that, even keeping like a card or a list, an up-to-date list of medications. I've seen people do that as well. We'll ask them a question about medications and they'll say, hold on, I have my list here. And that's great. I can't recommend that enough. It really helps with helping guide these types of things.
And it sounds like there's more to come in terms of evidence-based guidelines in terms of the pharmacogenetics piece. That's going to be a big area.
It's a rapidly growing area. It's more and more as the cost of this type of stuff, the genetic stuff, comes down. I think that in the next 5 to 10 years we'll be seeing more and more genetic testing. It's already out there. I'm sure you've seen the ancestry type component of it, but the same tests are there for kind of analyzing your body's liver enzymes we mentioned that help you break down the drugs and kind of predetermine how your body's going to react to these drugs, so we can know that before we even try the medication. So it's an exciting area moving forward. I think there'll be a lot of expansion there in the next 5 to 10 years or so.
And last but not least, it sounds like a major point is the whole balancing act.
Right.
I mean, we want to prevent DVT and pulmonary emboli and clots and heart attacks and strokes, but these drugs are very effective. But the downside is the risk for bleeding. It's
definitely important to understand that and have that conversation with your doctor or your pharmacist, because, I mean, the term blood thinner, it just sounds kind of scary, right? Like, a lot of people were turned off to the drugs off the bat because it just sounds scary, or maybe they know family members that were on a blood thinner and eventually bled. But it's important to realize that there's a really strong data for their use in preventing the clots or treating the clots, preventing the heart attacks or second heart attacks, preventing the second strokes or the first strokes if someone has AFib. The data is very strong that, you know, we have less of those kind of catastrophic events when we're on it. But on the flip side, you have to be in tune with that bleeding risk and always be aware that when I'm on these medications, I need to be watching out for, you know, if I'm brushing my teeth and my gums are bleeding a lot, or if I'm having a lot of nosebleeds, or if I notice blood in my urine or stool, then it's something you definitely would want to tell your doctor about immediately. So we try to find that balance as best as we can, and a lot of times we're successful, but it's always good to be aware that it is a balancing act, and too far on either side, so not taking the medication at all or overdoing it with the medication can be dangerous. So just have those conversations with your physician, your pharmacist, and try to take it as prescribed and find that middle balance.
Well, thank you so much, Scott, for all that information. It's very important that people understand about these medications, that they are very effective. But, of course, you said have that conversation with your doctor about the risk and so forth. But, again, I appreciate you coming in to talk to us about this.
Thank you for having me. It's been a pleasure.
And thank you for joining us for this edition of Focus on Health here on PAC 14.